Hello everyone. Today we are going to discuss about the physiological changes in pregnancy. The physiological changes in the pregnancy are caused by the hormones secreted by the placenta. These physiological changes include changes in the biochemical test results. Additionally, decompensation leading to unmasking of the pre-existing disease in pregnancy is also common. So let's talk about the fluid and the electrolyte changes. The so-called physiological anemia of the pregnancy. It is the result of differential increase in the plasma red cells and the white blood cell count. The plasma volume increased by 40 to 50%, whereas the red cell volume increased by only 15 to 20%, leading to hemodilution and the decreased blood viscosity by approximately 20%. Mediators such as renin, angiotensin, aldosterone, atrial natriuretic peptide, estrogen, progesterone, nitric oxide are postulated to cause increase in the total body water, consequently plasma volume. This expansion in the total body volume is about 6.5 to 8.5 liters at a time and is distributed throughout the maternal and fetal unit. These changes are helpful in protecting the mother and fetus from the disastrous effect of the peripartum hemorrhage. The increased plasma volume change increases the volume of distribution of some drugs and impact their clearance. The osmotic threshold for the thirst and the antidiuretic hormone release is lower by 10 osmoles, leading to increased water intake and retention of electrolyte. This causes cumulative retention of approximately 500 to 900 mmol of sodium and 350 mmol of potassium over course of pregnancy. However, despite retention of this electrolyte, increase in the plasma volume leads to lower mean serum sodium and potassium concentration over 12 weeks of gestation. Now, the next is acid-base regulation. In order to ensure the efficient oxygen delivery to the growing fetus, there is 30% increase in the 2,3-diphosphoglycerate, which leads to the rightward shift in the oxyhemoglobin dissociation curve. In contrast, increased minute ventilation leads to the respiratory alkalosis due to decrease in the PCO2 and the left shift of the same curve. Labor causes maternal hyperventilation and is associated with acute left shift of oxyhemoglobin dissociation curve. This reduces oxygen delivery to the fetus. However, prolonged labor leads to the increase in the oxygen consumption and basic metabolic rate, which leads to the result in lactic acidosis and right shift of oxyhemoglobin dissociation curve and decrease in maternal oxygen. Now about hematological changes. Hematological changes in pregnancy lead to adaptations, which increases the risk for anemia, thromboembolism, and consumptive coagulopathies. The levels of clotting factors like 1, 7, 8, 9, 10, 12, and fibrinogen are elevated. Platelet production and aggregation are also increased. The level of endogenous anticoagulant like protein S are increased and resistant to activated protein C develop. Additionally, the placenta generates the plasminogen activator inhibitor, thus impairing fibrinolysis. This creates an overall state of hypercoagulability. Though this is the mean to prevent bleeding at the time of delivery, there is high risk of thromboembolic phenomena. The red cell mass increased by 20% to 30%, but coupled with disproportionate increase in plasma volume, a state of anemia exists during pregnancy. The white blood cell count remains on the higher side throughout the pregnancy, but sharp rise is seen during labor and immediately after that. So after delivery, autotransfusion leads to about 500 ml of the blood returning to the circulating volume. This autotransfusion has the potential to complicate the peripartum course in female with cardiac disease and preeclampsia. So this is the summary of the hematological changes in pregnancy. So there will be the decrease in hematocrit by 35 to 45%, decrease in plasma 14 by 10 to 14%, decrease in antithrombin 3 platelet and plasma oncotic pressure. The mean corpuscular hemoglobin concentration will be unchanged. Lymphocyte and bleeding time will be unchanged. But there will be increase in blood volume, plasma volume, red blood cell, WBC count, clotting factor 1, 7, 8, 9, 11, prekallikrein, 1 Wilbrand factor, and thrombin. and there will be also increase in the activated partial thromboplastin time, prothrombin time, fibrinogen levels by 50% to 80%, renal erythropoietin and reticulocyte count, RBC to 3 DPG, serum albumin concentration, hydrostatic pressure, ESR, and serum lipid by 40 to 60%. Then about respiratory system. Respiratory hormone affects the vasculature of respiratory tract mucosa and causing capillary engorgement and swelling, resulting into the nasal congestion, voice change, and infection of upper respiratory tract. So this means smaller endotracheal tubes are required for intubation, and there is increased potential for bleeding on manipulating the air. The total lung capacity of the lungs decreases slightly due to significant upward displacement of diaphragm by gravid uterus, which is offset by compensatory increase in transverse and anterior posterior chest diameter by 5 to 7 centimeter, as well as flaring of the ribs. As the pregnancy advances, there is progressive decrease in expiratory reserve volume, residual volume, and functional residual volume, which reaches approximately 20% at term. Progesterone induces the muscle relaxation, also reduces the airway resistance, and lung compliance remains unchanged. There is 40% rise in tidal volume and 15% rise in respiratory rate, leading to progressive increase in minute ventilation to about 50% above normal by second trimester. Alveolar ventilation increased to about 70% higher than pre-pregnancy level values by end of gestation. Hyperventilation leads to respiratory alkalosis with decreased alveolar and arterial CO2 level. As involuntary response to pain, hyperventilation is further augmented in labor and could lead to marked alkalosis and shift to left of the oxygen dissociation curve, thus reducing the release of oxygen to the fetus. Similarly, oxygen consumption also increases to additional 20% to the term, which further increases to more than 60% during labor. Now, changes in the lung volume. So tidal volume will increase by 20 to 40%. Functional residual capacity will decrease by 20%. Expiratory reserve volume will decrease by 20 to 30%. Residual volume will be decreased by 20%. Vital capacity upon forced expiratory volume will be unchanged. Then about cardiovascular system. The heart size increases due to both chamber hypertrophy and dilatation, which can lead to movement of the apical pulse upward and laterally and mild tricuspid regurgitation. Systemic vascular resistance decreases steadily over the course of the pregnancy, while pulmonary artery pressure remains normal. In addition to progesterone, nitric oxide leads to smooth muscle relaxation and fall in SVR. There is increase in vascular sensitivity to vasoconstrictor agent as well. The vascular tone is more dependent on sympathetic control, so hypotension develops more readily and more markedly, consequently to sympathetic blockage. The central venous and the bronchial venous pressure remains unchanged, but femoral venous pressure is progressively increased due to mechanical factor. Thus, there is reduction in afterload and increase in the preload, together with increase in the blood volume that may produce functional murmur in addition to those due to anatomical changes. So cardiac output will increase to 30 to 40% higher level than in non-pregnant state in first trimester. So this increase in cardiac output can contribute to increasing both stroke volume and heart rate. So cardiac output will be highest in knee, chest, and left lateral position, and least in standing and supine position. So cardiac output increases even further during labor in response to catecholamine secretion due to pain and addition of 500 to 300 ml of blood into venous system by contracting uterus. After delivery, there is further increase in body volume by autotransformation, leading to increase in cardiac output by 50%, which makes this hazardous time for parturient with heart disease. Now about gastrointestinal system. Increase in level of HCG causes estrogen production, leading to nausea and vomiting, which occurs in the first trimester in up to 70% of the patient. It resolves on its own with supporting therapy in about 60%, by the end of first trimester and 90% by 20 weeks of gestation. A small fraction of the female may suffer from persistent vomiting, profound dehydration, electrolyte imbalance, weight loss, and often necessitating hospitalization in a condition called hyperemesis gravidae. Progesterone increases relaxation of lower esophageal sphincter and upward displacement of stomach due to enlarging uterus, leading to progressive increase in the reflux and heartburn. The intestinal emptying time increases, however, leading to increased propensity for consumption or constipation. Therefore, in spite of normal gastric emptying time throughout the pregnancy, the female remains at high risk of aspiration. This, however, changes during labor, where gastric emptying time also increases significantly, increasing the risk of aspiration exponentially. This reverts to pre-pregnancy risk value in 24 to 48 hours after delivery. There is impaired motility of gallbladder with delayed emptying. This leads to the development of biliary sludge and gallstones. Thus, pregnant female have a progressive increase in residual volume of gallbladder throughout the pregnancy, which return to normal volume shortly after delivery. Hepatic transaminases, gamma glutamyl transferase, bilirubin, and lactate dehydrogenase are increased slightly in pregnancy, and some others suggest that this enzyme level reduces during pregnancy. Alkaline phosphatase is markedly elevated due to placental production. Spider neva and Palmar edema may occur without clinically significant liver disease. Now, renal system. Increased cardiac output leads to increase in renal plasma flow and glomerular filtration rate by up to 50%. As a result, the plasma, blood urea, nitrogen, and creatinine concentration reduced by about 40 to 50%. Increased GFR overwhelmed the capacity of the renal tubule to reabsorb glucose amino acid might not be absorbed as efficiently. Hence, mild glycosuria and amino acid urea may develop in normal gestation. Physiological diuresis during postpartum period occurs between second and fifth day. The GFR and blood urea concentration slowly return to non-pregnant state by sixth postpartum week. After 12th week of gestation, progesterone-induced relaxation leads to dilatation and atony of the renal calyces and ureter. This promotes urinary stasis and combined with mechanical obstruction due to growing uterus increase the risk for urinary tract infection. Now about central and peripheral nervous system. Both the CNS and PNS display an increased sensitivity to anesthetic agent, which is reflected as decreased minimum alveolar concentration and profound and prolonged block with decreased dose requirement of local anesthetic for peripheral block. Due to venous engorgement, there is reduction in the epidural space and increase in CSF pressure. This reduces the amount of local anesthetic that is required for epidural blockage. About endocrine system, increased pregnancy hormone changes the internal milieu and thus leads to the changes in the hormone level. Beta HCG stimulates the TSH receptor, leading to transient hyperthyroidism and thus follicular hyperplasia, causing increase in size. So there is increase in the thyroid binding globulin, but normal free T3 and T4 levels are seen. Fasting blood glucose is lower in the pregnant than in non-pregnant female. But tolerance to the glucose load, which causes early glycosuria, may be somewhat impaired due to action of placental lactogen, producing mild diabetogenic state. In addition, lower fasting blood sugar in a pregnant patient mask underlying insulin resistance and secondary to placental secretion of human placental lactogen. Occasionally, this progress to gestational diabetes. Glucose responses return to normal promptly after delivery of the placenta. Unlike insulin, glucose readily crosses the placenta. Babies of diabetic mother thus run a higher risk of higher birth weight and may potentially develop both hypoglycemia and even hypoglycemic season soon after they are born. Secretion of corticosteroid hormone by adrenal gland is increased, and there is adrenal cortical hyperplasia. Higher cortisol level can also lead to further insulin resistance and increased skin pigmentation. Now about metabolic change. To provide for growing fetus, increase basal metabolic rate and oxygen consumption of mother, protein, fat and carbohydrate metabolism is increased. The presence of high concentration of human placental lactogen, progesterone, prolactin and cortisol in presence of reduced glucokinase and phosphofructokinase activities cause an insulin resistant state. About musculoskeletal changes, relaxin and estrogen are responsible for increased ligamentous laxity, especially in the pelvis. While the laxity enables the fetus to be accommodated easily, it can also contribute to the musculoskeletal pain and poses an increased risk of subluxation or dislocation. Dermatological changes, hyperpigmentation of certain part of the body, such as face, neck, midline of the abdomen, is not uncommon during pregnancy. Melanocyte stimulating hormone is responsible for this change. Striae gravidum are also seen towards the end of the pregnancy. Ocular changes, increased progesterone level, relaxing, and decreased production of aqueous humor leads to decreased intraocular pressure, which in turn could lead to visual disturbances and contactless intolerance. This is the overview of changes in various systems. Cardiovascular system, there is increase in heart rate, stroke volume, cardiac output, left ventricular hypertrophy, regurgitant murmur, and decreased systemic vascular resistance. Then respiratory system, there will be increase in the minute volume, increase PaO2, decrease PCO2, and decrease functional residual capacity. GI system, there will be decreased lower esophageal sphincter tone, increased risk of aspiration, decreased liver enzyme, and increased air. About renal system, there is increased renal blood flow and GFR, decreased plasma urea and creatinine, increased urinary protein and glucose, and increased risk of UTI. About musculoskeletal system, there is increased ligamentous laxity and increased risk of dislocation. About endocrine system, there is increased progesterone, estrogen, thyroid hyperplasia, transient hyperthyroidism, insulin resistance, increased cortisol secretion, placenta secretion of relaxin, human placental lactogen, and human chorionic gonadotropin. About neurological changes, there is increased CSF pressure, engorgement of epidural vein, increased sensitivity to local anesthetic, decreased minimum alveolar concentration. Dermatological changes, there is hyperpigmentation of face, neck, abdomen due to melanocyte stimulating hormone and the stria gravidum. Ophthalmological changes, decrease aqueous humor and intraocular pressure. Metabolic acid-based changes, 30% increase in 2,3-DPG, increased metabolism of carbohydrate, protein, and fat. Thank you, guys.